From conflict to consensus, breast cancer screening at age 40, a divided medical community. The medical community has been divided for decades over the appropriate age to begin screening mammography for breast cancer and how frequently these mammograms should be performed. This division has been characterized by contrasting approaches, often labeled as skeptics and interventionalists, as detailed in Asia Friedman's book, Mammography Wars. Skeptics prioritize minimizing the potential harms of overdiagnosis and overtreatment, whereas interventionalists emphasize early detection to improve survival rates. A significant development: new guidelines. The U.S. Preventive Services Task Force, USPSTF, recently modified its breast screening recommendations. This modification has led to a consensus among the American Cancer Society, ACS, the American College of Radiology, ACR, and the National Comprehensive Cancer Network, NCCN, that screening mammography should commence at age 40. The impact of evidence-based medicine. This alignment is a significant milestone and underscores the dynamic nature of evidence-based medicine and its ability to reshape healthcare recommendations for the betterment of public health. It highlights the delicate balance between avoiding the overuse of medical resources and ensuring that early detection does not miss potentially life-saving diagnoses. The agreement on the starting age for screening marks a milestone in prioritizing population-based guidelines and individual clinical experiences. USPSTF's latest guidelines. The USPSTF's latest guidelines recommend that all women undergo biennial mammography starting at age 40 and continuing through age 74 to reduce mortality from breast cancer. This is a significant shift from the previous approach, which encouraged women in their 40s to make individualized decisions based on their health history and preferences. The new guidelines reflect a growing body of evidence suggesting that screening at age 40 can save more lives. This shift in policy underscores the importance of periodic reassessment of medical guidelines in light of new research and evidence. Frequency of screening points of contention. The consensus among significant health organizations remains the same as the importance of individualized care. While the starting age for screening is now uniformly recommended, the annual or biennial frequency remains a point of contention. The American College of Radiology recommends annual screenings starting at age 40. The American Cancer Society, for example, recommends annual screenings for women aged 40 to 54, followed by biennial screenings for those 55 and older, while the USPSTF advises biennial screenings throughout. Despite these differences, the agreement on the initial age for screening represents a significant convergence of expert opinion. Addressing health disparities. One of the critical aspects of the USPSTF's recommendations is the call for more research to address health disparities in breast cancer screening and treatment. Women from Black, Hispanic, Latin, Asian, Pacific Islander, Native American, and Alaska Native communities often face unique challenges and disparities in healthcare access and outcomes. Black women, in particular, are 40% more likely to die from breast cancer than white women and are more prone to aggressive cancers at younger ages. Ensuring screening starts at age 40 is a crucial step but insufficient alone. There's an urgent need for more tailored screening strategies that can better serve these populations and improve equity in breast cancer outcomes. Dense breasts, a special consideration. Additionally, nearly half of all women have dense breasts, which can both increase the risk of breast cancer and reduce the effectiveness of mammograms. The task force acknowledges this issue and calls for more research on the benefits and harms of additional screening methods, such as ultrasound or MRI, for women with dense breasts. This highlights a broader challenge in medical practice, balancing population-based guidelines with individual variations in risk and response to screening. The role of evidence-based medicine. The convergence of prominent health organizations on the starting age for breast cancer screening is a testament to the power of evidence-based medicine. Over the years, a wealth of research has contributed to our understanding of the benefits and harms of different screening strategies. Adapting and refining guidelines in response to new evidence is a hallmark of a robust healthcare system. This process enhances the quality of care and builds trust in medical recommendations among the public. Integrating research and clinical expertise. Evidence-based medicine plays a crucial role in navigating the complexities of healthcare decision-making. It allows for integrating clinical expertise, patient values, and the best available evidence. The recent alignment of screening guidelines exemplifies how continuous research and dialogue can lead to more effective and equitable healthcare practices, a significant achievement. The agreement among major healthcare organizations to start breast cancer screening at age 40 represents a significant achievement in the ongoing effort to improve public health. Despite differing opinions on the frequency of screening, this consensus underscores the importance of evidence-based medicine in shaping healthcare policies. By balancing the need to avoid overdiagnosis with the imperative to detect cancers early, these guidelines reflect a nuanced approach to population health. Evidence-based medicine is a journey of continuous improvement, and this convergence in screening guidelines is a step forward. Continuing the journey, as we celebrate this milestone, we must continue advocating for research and policies that ensure all women receive the care they need to live longer, healthier lives. It is vital to heed the call for more research to address health disparities and improve screening for women with dense breasts, highlighting the ongoing commitment to refining and enhancing healthcare recommendations. Summary of USPSTF Final Recommendation. Screening for breast cancer. April 2024. What does the USPSTF recommend? Grade B. Women aged 40 to 74 years. The USPSTF recommends biennial screening mammography. Statement. Women 75 years or older. The current evidence is insufficient to assess the balance of benefits and harms of screening mammography in women 75 years or older. Statement. Women with dense breasts. The current evidence is insufficient to assess the balance of benefits and harms of supplemental screening for breast cancer, using breast ultrasonography or magnetic resonance imaging, MRI, in women identified to have dense breasts on an otherwise negative screening mammogram. To whom do these recommendations apply? These recommendations apply to cisgender women and all other persons assigned female at birth, including transgender men and non-binary persons, 40 years or older at average risk of breast cancer. They also apply to women who have factors associated with an increased risk of breast cancer, such as a family history of breast cancer, i.e., a first-degree relative with breast cancer, or having dense breasts. These recommendations do not apply to persons who have a genetic marker or syndrome associated with a high risk of breast cancer, e.g. BRCA1 or BRCA2 genetic variation, a history of high-dose radiation therapy to the chest at a young age, or previous breast cancer or a high-risk breast lesion on previous biopsies. What's new? For the current recommendation, the USPSTF recommends biennial screening mammography for women aged 40 to 49 years, rather than individualizing the decision to undergo screening for women in this age group. This recommendation is otherwise consistent with the 2016 USPSTF recommendation on screening for breast cancer. How to implement this recommendation? Screen women aged 40 to 74 with a mammogram every 2 years. Both digital mammography and digital breast tomosynthesis, or 3D mammography, are effective mammographic screening modalities. To achieve the benefit of screening and mitigate disparities in breast cancer mortality by race and ethnicity, it is important that all persons with abnormal screening mammography findings receive equitable and appropriate follow-up evaluation and additional testing, inclusive of indicated biopsies, and that all persons diagnosed with breast cancer receive effective treatment. There is insufficient evidence to recommend for or against screening for breast cancer in women 75 years or older. There is insufficient evidence to recommend for or against supplemental screening using breast ultrasonography, or MRI, in women who have dense breasts. Clinicians should use their clinical judgment regarding whether to screen for breast cancer in women 75 years or older and regarding whether to use supplemental screening in women who have dense breasts and an otherwise normal mammogram. The USPSTF recognizes that clinical decisions involve more. This clinician summary may be used and reprinted without considerations than evidence alone. Clinicians should understand specific permission, provided it is reproduced without the evidence, but individualized decision-making to the specific changes, and not sold for profit or incorporated into a patient or situation. Profit-making venture. What additional information should clinicians know about this recommendation? There are pronounced inequities in breast cancer stage, at diagnosis, subtype, and mortality. Black women are more likely to be diagnosed with breast cancer beyond stage 1, are more likely to be diagnosed with triple-negative cancers, i.e., ER, PR, and HER2, which are more aggressive tumors and are approximately 40% more likely to die of breast cancer compared with white women. Why is this recommendation and topic important? Breast cancer is the second most common cancer and the second most common cause of cancer death among U.S. women. In 2023, an estimated 4,370 women died of breast cancer. What are other relevant USPSTF recommendations? The USPSTF has issued recommendations on the use of medications to reduce women's risk for breast cancer, as well as risk assessment, genetic counseling, and genetic testing for BRCA1 or BRCA2 related cancer. What are additional tools and resources? The National Cancer Institute has information on breast cancer screening for healthcare professionals and for patients. The Centers for Disease Control and Prevention has information on breast cancer screening. Where to read the full recommendation statement? Visit the USPSTF website or the JAMA website to read the full recommendation statement. This includes more details on the rationale of the recommendation, including benefits and harms, supporting evidence, and recommendations of others.